see my slides?
Yes.
Okay, great. Okay, so hello everyone. My name is Sean Garcia. I'm a registrar in trauma and orthopedics in the UK. My talk will be, sorry, the title in the program is slightly wrong. I'll be talking about the efficacy of telephonic consultations for new patients in elective orthopedic clinics. So just a bit of background. With the advent of the COVID-19 pandemic, for patient safety as well as the safety of healthcare professionals, a decision was made across our hospital trusts to run clinics using telephonic consultations rather than face-to-face appointments. And this included new visits as well as follow-up appointments. We elected to work out if this was effective. So we did a simple retrospective analysis and observed the outcomes of the new consults for orthopedic patients. And the rationale for this, or at least the thought process behind it, is that telephone consultations aren't exactly new. And there is literature in the past, even up to this year as well, that considers telephonic consultations as something that we should be engaging more in. Patients find it convenient for them. And with COVID, they thought it was a bit safer that they didn't have to come into a hospital. But of course, as health professionals, we find that clinical assessments can't be comprehensive because you can't do a physical exam on these patients. And then for medical legal reasons as well, not being able to do a full assessment on these patients could be detrimental. Nonetheless, all of these studies here suggest that telephonic consultations are actually an avenue that should be explored in the future, in particular in orthopedics. So the objectives of our small study was to determine how effective these telephonic consultations are, but specifically for new elective orthopedic patients. Most of the papers we came across were for follow-ups, or they did include new patients, but that subset of the study was small. We wanted to see our outcomes primarily were to determine if most of the new clinic appointments went on to become face-to-face follow-ups, meaning that consultants weren't happy with the telephonic consult and still wanted to see the patient face-to-face anyway. And then we wanted to see if there was a specific percentage of patients who had telephone consults that actually got a clinical decision made at that appointment rather than having to have a subsequent face-to-face visit and then have a clinical decision made. So data was collected retrospectively. This was done last year during the pandemic peak in a 3-month period. It was collected from 2 hospitals across our trust, and all of the outcomes of new telephonic consultations were documented based on patients' clinic letters. So our outcomes were divided into a few categories. Either patients were sent for investigation, so this could have been subsequent radiographs or MRIs, if a face-to-face consult was arranged as a follow-up for clinical examination, if the patient was sent for physiotherapy, if the patient was added to a waiting list for surgery, or any other thing that may have occurred, if they were discharged, for example. All the new patients had phone consults with an orthopedic surgeon consultant who made these decisions. So inclusion criteria, all orthopedic patients, new ones who were admitted to the clinic for telephone consults. So we excluded follow-ups, whether that be over the telephone or face-to-face. We excluded fracture clinic as well. So this study primarily focused on elective clinic, orthopedic clinics, rather than fracture clinics. And spine clinic was excluded as well. In total, we had a population of 519 new elective patients over a 3-month period. And we went on to categorize that based on subspecialty and then the outcomes. So by subspecialty, we found that the majority of patients coming to clinics, at least, were primarily going to hip and knees and hand clinics during that period of time, with foot and ankle and shoulder and elbow bringing up the rear. In terms of the overall outcomes of the new telephonic consults, we found that over half of the patients who had a telephone consultation went on to have a face-to-face consult. And generally, most or all of the letters, the specific reason for that is because that clinical examination could not have been done over the phone, because this is simply a telephone consultation and there's no video, and the consultant is not able to interact with the patient. There's no physical exam that could be done. Some patients did get sent for investigation, approximately 14%, 15% were added to the list, and I'll go into a bit about what that may have entailed. 1% were referred to physiotherapy. So with foot and ankle, an overwhelming 62% we found were generally required face-to-face consults. And again, a very small amount were added to a waiting list for surgery or sent for investigation. And similarly with shoulder and elbow is a bit less in terms of the face-to-face, 51% versus 62%. But still a significant proportion of patients were called in for a face-to-face consult rather than making a decision straight away over the telephone. 19% in this case was sent for investigation. And with this, we found that there were patients who they had a telephone consult, the radiographs were available, and the consultant suspected possibly a rotator cuff pathology and requested an MRI. But with that request also came a face-to-face follow-up so that they can review the MRI and also clinically examine the patient. This was not a frequent occurrence, but it was something that occurred specifically in shoulder clinic. In terms of hand clinic, we found that actually less patients were called in for face-to-face consults, but it was still at 48%. We found that surprisingly, there were 20% of patients added to a waiting list. But specific to hand surgery, we noted that many patients were referred in by their GP or referring doctor for carpal tunnel syndrome. And that sort of skewed the results in hand surgery, where they had specific clinical findings over the telephone. The consultants were happy with the clinical history, and they had nerve conduction studies as well, which confirmed the diagnosis. So it would appear that in those situations where many investigations were available and many things pointed to a specific diagnosis, that the consultant was happy to add this patient to a list. That being said, those patients were still reviewed at a pre-assessment clinic before actually going into surgery. So there wasn't any patient who was added to a list and then not seen at all prior to the operation. For hip and knee, a similar situation, the majority of patients required a face-to-face consult, and those who were added to the list or sent for an investigation had a subsequent face-to-face visit for follow-up anyway. So what we garnered from most of this was that telephone consultations, at least for new patients, they often provide insufficient information to make a clear clinical decision, a diagnosis or a provisional diagnosis can be made, but without clinical examination, the assessment is not comprehensive. You lose the visual cues that you might pick up with seeing a patient physically. This may be corrected for with video consults, which could be something that one could look at into the future, but for now, we were specifically looking at telemedicine. At least for our trust, we found that face-to-face consults remain the preferred choice for clinical diagnosis, and this we based on the outcomes that our consultants chose. And like I said before, the patients that were added to lists and sent for further investigations were invariably called for a face-to-face consult after the initial first telephonic consult. Telephone consults may have a role in clinic triage, which was a point that was brought up earlier when we had originally discussed this, but we found that it may lead to a waste of resources as well. And some patients might be better off, or some clinics might be better off simply just having that face-to-face consult, making a clear diagnosis and plan, rather than have a telephone visit and then have a subsequent face-to-face visit after. Limitations of the study. So we found that the study certainly does not account for variability in clinical complexity. And in those cases, obviously, a face-to-face consult is generally recommended. Certain consultants have different personal preferences. So some consultants did not want to do telephone consults at all, and generally would have an initial consult, but would not make a decision and would rather see their patient face-to-face. And that is it. Does anyone have any questions?
Thank you, Dr. Sean. And I would like to ask that, how could you manage the liability of telephone consultation?
So that was a big concern for many. And so I think that is why the majority still went on to have a face-to-face consult anyway. And even the ones that did request investigations or added to a waiting list, there was always a disclaimer that they would see the patient prior to whatever was being done surgically. So it meant that the patient came to a consent clinic, for example, and at that consent clinic, in getting the consent, the consultant would examine the patient and work out if that surgery was indeed indicated. So the actual decision for surgery happened at that time rather than over the phone. So it was a compromise because of COVID that clinics will run this way. At the moment, they're not run this way anymore. It's primarily face-to-face now with occasional telephone consults, but that was a big concern, the legal liability.
Thank you.
Thank you, Dr. Garcia. Does anyone else have any questions? Okay, I think we can move on to the next talk. Thanks again, Dr. Garcia. It was a great talk, especially during the pandemic, since telemedicine has become so much more common. I agree, it's not for every clinic.
Yeah.
So thanks a lot. Yeah.
Yeah, thank you.